It's now my great pleasure and privilege to introduce Dr. Robert Heinssen to you. I mentioned him earlier this morning. He is the Director of the Division of Services and Intervention Research at the National Institute of Mental Health in Maryland, in Washington. And Bob's got you can read his CV here, but on a more personal note, Bob was a clinician working in Chestnut Lodge many years ago, and he made a move into the heart of the National Institute of Mental Health. And he's a very unusual person because many people in those roles just play the traditional bureaucratic game and the administrative game, but Bob, building on his clinical experience and I think his vision for seeing early intervention progress in the United States, has really facilitated a huge change which has been research driven, evidence driven, and it's a very, very impressive thing to have observed over the years, and I think everyone should be very grateful to Bob. And now he's going to tell you about these developments and how they've come to fruition through the research studies that he and NIMH have been funding over the last few years. So I'm really looking forward to hearing about it. So over to you, Bob.
Good morning, and Pat, thank you very much for that warm welcome, and thank you to the IEPA Organizing Committee for inviting me to give this presentation. It's a pleasure to be here today to talk with you about the recovery after an initial schizophrenia episode research initiative from the United States, and to give you an idea about what the future may hold. So as I start, first to tell you that I have no financial conflicts of interest with this presentation, and also any views that I express today are solely my own, and they don't necessarily represent the official opinion of the National Institute of Mental Health or the US federal government. So here we are in Milan at IEPA 10, and the conference theme is looking backward, moving forward. So this is really a nice opportunity for me to look back with you at the origins of the RAISE project, to tell you, to update you on what's been accomplished to date, where we stand in 2016, and where this initiative is moving in the next several years, taking us out to 2020. So I'll start by going back to 2008 with a little bit of a look back. And first to tell you, that's what I looked like in 2008. So I'm happy to say that I haven't aged much in the last 8 years. RAISE started in 2008, but I think it's important to recognize that RAISE was built on a backdrop of accomplishments from the international community, going back to the pioneering work of Pat McGorry and his Australian colleagues in really charting what would be a model for early intervention in first episode psychosis. That work in Australia spawned many studies, first observational studies, then case control studies, quasi-experimental studies, culminating in a series of randomized controlled trials in the early 2000s, notably studies from the UK, from Denmark, and from Norway, the LEO, the OPUS, and the TIPS project in particular, that really illustrated that there was a better way of approaching illnesses such as schizophrenia and other psychotic disorders. And the summary of all those studies is no surprise to members of this audience. That work gave a very strong signal that early intervention matters. And then in fact, the expectation that we had of chronic impairment and chronic disability in schizophrenia was not a given, but that in fact those outcomes might be improved by interventions that were offered early after the onset of psychosis and addressed the multiple needs of the person in terms of recovery from symptoms, recovery of functioning, and recovery of hope. So NIMH, building upon this framework, tried to explore how this work would be relevant to the US context. And at the very start of the project, we reached out to important stakeholders Our thought was we wanted to design a research program that was highly relevant to the needs of policymakers that are responsible for caring for people with serious mental illness over the course of their life, and also important advocacy and professional groups that also play a role in our service system. So our idea was by engaging these important stakeholders early, we would engineer the eventual dissemination and adoption of the study findings. So specifically, we looked out to federal agencies that were interested in supporting recovery-oriented care for schizophrenia and other psychotic disorders, those that were interested in preventing disability, that would impairments that would keep people from being able to enter the workforce, and other agencies that are responsible for financially supporting the care of individuals with psychosis. Our research investigators also reached out to state mental health administrators who are very involved in the care of serious mental illness in the United States. And researchers and NIMH alike reached out to important advocacy groups such as the National Alliance of Mental Illness at the very start of the project to assure that the project was relevant to their needs, would generate information that would be useful, and would give us tools and technologies that might be able to change the way that treatment for early psychosis was approached in the United States. It turned out in the end that engaging those stakeholders, those advocates, was extremely important in convincing the US Congress that we had the opportunity to improve our practice and change outcomes. And I'll tell you a little bit more about that as the story unfolds. So the RAISE research questions in 2008 were really three. First, we were interested in seeing whether it would be feasible in the United States to implement the kind of integrated treatment programs that had been tested in LEO and in OPUS, whether we could do that in community-based treatment centers using the existing workforce retrained for these new techniques. So the first question was, could we do that in the United States, which has a very different healthcare system and a very different way of organizing care compared to European and Scandinavian countries. If we were able to do that feasibly, the second question was, would that approach be effective compared to typical treatment in terms of symptomatic improvement and better functional outcomes? And then third, we wanted the research organized in such a way that the findings would provide tools and strategies that would spur broad implementation of this evidence-based treatment across the United States at the close of the project. So those were the questions that we threw out to the research community. And in terms of the approach, we eventually came to call this integrated care program coordinated specialty care. And again, these elements will be no surprise to you. We were asking our researchers to put together a suite of services that would include stage-specific pharmacotherapy, recovery-oriented cognitive and behavioral therapies, family education and support, and supported employment and education, supported by case management services if they were necessary. To put these things together in a treatment package that would be offered to the service user within the context of a shared decision-making framework, so that the person and the providers would decide in a collaborative way on which interventions made sense, how long they would be applied, and what kinds of outcomes would be pursued in the treatment. So we were looking for this model of team-based, multi-component specialty care for first episode psychosis and comparing that to typical care that was available in community sites in the US. So we funded 2 research studies. The RAISE Early Treatment Program was a randomized control trial led by John Kane, Nina Schooler, and Delbert Robinson, and an implementation study, the RAISE Connection Program, led by Lisa Dixon, Jeffrey Lieberman, Susan Essick, and Howard Goldman. So together, these two studies complemented one another in that they would look at the questions of feasibility, effectiveness, and implementation. So to tell you a bit about the RAISE, the Early Treatment Program clinical trial, John Kane presented the initial outcome results from this trial at the last IEPA meeting in 2014. And in fact, John, Nina, Delbert, and Kim Muser will be presenting some additional findings this afternoon in a symposium here at IEPA 10. But this, you can see, this was a complex trial. It involved 34 clinical sites in 21 states. It compared the coordinated specialty care versus typical treatment in the community. It involved a total of 404 individuals with first episode psychosis. It trained several hundred clinicians that were already employed in these community clinics in a new set of clinical skills, and it applied this treatment over a 2-year period and looked at outcomes. Those results were published online late in 2015, in October 2015, and I'll just summarize those results that the coordinated specialty care intervention called Navigate was superior to typical care in terms of the rate of recovery of quality of life, overall symptoms, depression, and work and school outcomes. It was superior both in terms of the rate of recovery and the overall degree of recovery over a 2-year period compared to typical care. Importantly, it also showed that duration of untreated psychosis was a very powerful moderator of the treatment effect. In this study, the median duration of untreated psychosis was 74 weeks. So an analysis of people who had DUP of less than 74 weeks versus those with greater than 74 weeks showed that the intervention effects were noticeably more robust for the lower DUP group. Essentially, the effect size doubled for individuals who had the lower DUP. So echoing a statement that Pat made earlier, we concluded from this it was not enough just to offer the right treatment, but it's also important for us to offer the right treatment at the right time. And that was in addition to that, a subsequent paper explored the cost effectiveness of this program and showed that indeed early intervention is cost effective, and when it's offered to people in the low DUP condition, it's extremely cost effective, a great value for the dollars invested. I'll also say NIMH funded an additional trial, one that complemented the RAISE ETP trial. This was from Vinod Srihari and his colleagues at Yale. This was the specialized treatment for early psychosis trial that tested another version of coordinated specialty care versus typical care for first episode psychosis, also offered within a publicly funded community mental health center in New Haven, Connecticut, and essentially replicated findings from the RAISE trial in terms of superior symptomatic improvement, reduction in hospitalization, and also recovery of vocational functioning among participants of the coordinated specialty care condition. So by the end of 2015, we actually had 2 well-designed clinical trials from the US that demonstrated both it was feasible to do this kind of approach and compared to usual care, quite effective. Our implementation study from Lisa Dixon had a slightly different focus. This was a more intense look at the process of implementing coordinated specialty care in publicly funded community mental health centers. A notable innovation in this study was including state officials as equal partners, as research investigators. So the commissioners of mental health in New York and Maryland were intimately involved in the design, the conduct, and the interpretation of results from this study. And their charge here was to really understand what would be obstacles and barriers to training the existing workforce in new techniques, what would have to be done to improve detection of people with early psychosis, engaging them in care, and also developing the tools that would create high-fidelity programs that could be maintained over time. So the results of that study were also published in 2015, and in fact, that group was very successful in developing tools that would make it possible to replicate these coordinated specialty care programs in other state-run mental health programs throughout the United States. They also were successful in demonstrating that the coordinated specialty care was highly engaging to a population that's traditionally very hard to reach and engage in treatment, and that the tools for developing and maintaining these programs were practical for administrators and clinicians alike. So by the end of 2014, we had actually accomplished or gotten answers to 2 out of the 3 research questions from RAISE. Between the 3 programs, the 2 RAISE programs and the STEP program, there were a total of 20 coordinated specialty care clinics that had been established in the United States. We showed that you could train the existing workforce to implement those kinds of procedures. We showed that those programs were highly engaging to the service users who engaged in them, and that they could be maintained over time. In the RAISE ETP program, those sites existed for a total of 4 years and were able to keep continuing operation over that period of time. So we think the feasibility question has been answered. The 2 comparative effectiveness trials give us good evidence that in fact that is a superior way of approaching care for young people with early psychosis. But in 2014, we had yet to address the question of broad implementation of this approach. And here is where the efforts of our advocacy groups really played a role. Over the course of the study, we had kept them engaged with updates about research progress and what we were looking to accomplish. And I didn't know it at the time, but these advocacy groups were taking that information to the US Congress and saying there is a better way of doing things, and we demand that this be implemented more broadly. It turned out that in 2013, the Congress was very concerned and engaged with the question of mental health reform in the US. So this became, this early intervention model became a solution to their problem. They needed to do something, and this seemed to be something that they could invest in with reasonable assurance that it would pay off. So in early 2014, the Congress increased the funding by $25 million and set it aside for these types of evidence-based treatment programs for first episode psychosis. And then importantly, they directed NIMH and the Substance Abuse and Mental Health Service Administration, that's the federal agency responsible for mental health care in the US, they instructed those 2 agencies to work closely together to provide guidance to the states that would help them to establish high-fidelity evidence-based treatment programs. So with that in mind, NIMH mobilized all of the products that had been developed in the 2 RAISE programs. We made them available to the state administrators who would be responsible for implementing these new funds. And we did it both through structured guidance about how programs could be set up and sharing the materials that had been developed in the research program. And this next slide will show you what some of those products were. John Kane's group and Lisa Dixon's group developed treatment manuals, recovery-oriented videos that could be used to train clinicians and also to facilitate the clinical work, and a variety of tools that would help programs plan for these types of treatment programs, to monitor their fidelity over time, to capture key outcomes, and so forth. All of these materials were made available to the states at no cost. Since the federal government had paid for the research, these were made freely available and, in fact, have been very widely adopted. We also, as part of our dissemination program, SAMHSA and NIMH embarked on a very ambitious program of education and training. There were 36 separate events that occurred over a 12-month period. that spoke to administrators, to clinicians in a variety of ways to get the message out about the program and then training in the specific interventions that were involved. We also had help in that an allied federal agency, the agency that's responsible for public insurance in the United States for mental health, our Centers for Medicare and Medicaid Services, in late 2015 gave an important endorsement to the research-based treatments that had been developed. It told the states that we recognize that these evidence-based approaches are the preferred treatment approaches for first episode psychosis, and importantly, that we will pay for them. So this gave a useful financial tool to the states to further support the implementation of the programs. On top of that, the Congress continued to support the implementation through 2 additional infusions of money. In 2015, they continued the $25 million investment. And then this year, in 2016, they actually increased the amount that would go to the states to $50 million. So there's been a total of $100 million US that have been distributed to the states over a 3-year period to support implementation of early psychosis programs. And I would mention that this kind of progress, both in terms of the funding and getting states interested in pursuing these new approaches, would not have been possible without the involvement of key stakeholders. I will make mention of one particular group, the EPINET group, led by Steve Adelsheim and Kate Hardy, is a consortium of about 200 researchers and clinicians in the United States who specialize in early psychosis care and have come together to create tools and opportunities for sharing the learning from the research programs and also disseminating these materials broadly to the newly developing programs. There'll be a symposium on PEPNET, I think it's tomorrow, and you could learn more about that by attending that symposium. So now some data. We had good science and we had some money. What difference has this made? What impact has it had on the US scene? Well, this graph will show you the rise in the number of states that have endorsed this early treatment model in their state plans. In 2008, before RAISE, there were only 2 states that were active in this arena. They had special plans. That was Oregon and California. And by 2014, at the end of RAISE, 2 more states had made official statements that they were moving this direction, Maryland and New York. So we had 4 states in 2014 before the block grant, before the federal funds became available. You can see the funding made a tremendous difference. By 2016, we went from 4 to 36 states declaring that they were going to move in this direction. There are 50 states in the United States, so 36 of them means 72% of our states are currently on board with offering first episode psychosis care. And with the infusion of new funds in 2016, we can project that 48 of the states, or 96% of the states in the US, will have these kinds of programs in 2 years by 2018. So that's the number of states in terms of plans. What about the number of clinics that exist in the United States? My clicker doesn't seem to be letting me advance. Somebody doesn't want you to see this data. Okay, here we go. So in 2008, before RAISE, as I said, there were 2 states that had plans, and it turned out that there were only 12 of these clinics that existed in the United States. I found out in 2010 how this came about, and this turned out to be the Australian invasion. So there was somebody in Oregon, Tamara Sale, who reached out to Pat McGorry and the EPIC group and said, you know, we know that you guys have a new way of treating early psychosis, and we would like to adapt this to the United States. And in fact, Tamara and her group adopted the EPIC model and adapted it to the US context. And by 2008, there were 12 clinics in Oregon that were offering this type of care. Well, after RAISE in early 2014, there had been an increase in the number of programs to 41. So those 29 additional programs, about half of them were related to clinics that had direct participation in the RAISE research programs. So these are programs that had been involved and decided to continue the approach after the research was over. So that was a nice increase from 12 to 41, about a tripling of the number of programs. But what happens when you add financial resources to the science? Well, what happens is this. In 2016, today, there are currently 114 coordinated specialty care programs operating in the United States in 36 states. These are actual programs. Staff have been hired, they've been trained, and people have been enrolled in these programs. These are actual programs that are treating patients today. So this is quite an impressive result. A lot of it due to the advocacy of both the family and the professional organizations to make these services more available. So this is what happens when you have advocacy and some resources. What happens when you double the amount of money that's available to the states for these programs? So in 2018, this is what the world will look like. 187 programs. Now, I promised my Australian colleagues last night that I would show you this. I just love doing this. I just love seeing that change. So in 2018, 187 community clinics. So this represents about a 15-fold increase in capacity over a 10-year period in the United States, which is quite remarkable. But it's the product of good science, good engagement with policymakers, and additional funding to support these services in a full way. So now we can say that at the end of 2016, I think the 3 research questions have been answered. It is feasible, it is effective, and it is scalable within the US context. So now we turn to what's next, what goes beyond RAISE. Well, it occurred to us at NIMH in 2015 that at that point we were projecting that there would be roughly 120 of these programs. And we started thinking it would be great if we had 120 individual programs that were offering evidence-based care in an excellent way. That would be a tremendous value to the nation. But if it were possible to integrate those 120 clinics into a network where they could be sharing both data, learning, and innovative thinking, that we would really have a powerful engine for both learning about and improving the quality of care. So the idea that we have is creating an early psychosis intervention network in the United States, EPINET. So we have a new EPI in the vocabulary here. And NIMH envisions this as a national learning healthcare network that would be established among these early psychosis clinics. And the way that we would help link them is by pushing standardized methods for measuring key characteristics of service users who are involved, the interventions that are delivered to them, and key outcomes that are related to care in early psychosis. We would then develop a unified informatics framework that would allow us to aggregate data across these clinics and then be able to report information about quality and performance back to the clinics so that they have a data-driven or measurement-based way of being able to evaluate their fidelity to evidence-based models, the quality of their care, and areas where they might improve their functioning. And then finally, a larger goal here is that we would like to establish a new culture of collaboration between people receiving care, the people offering care, and the researchers who study the care. That each of them has a stake in this network, in the treatment, and in the learning about it, so that we get high degree of participation from all of these groups in a collaborative enterprise that will help move us forward. So we've taken on several tasks in 2015, 16, and 17. We've done work to establish common data elements that would unify these programs. And for that, we've used a program that the National Institutes of Health established for creating common data elements in genomic research. They've developed a framework. The PHENIX process stands for phenotypes and exposures, but it's a process by bringing together thought leaders, experts in a content area, and walking them through a consensus process by which they identify measures that have sufficient rigor to be included in a toolkit. So NIMH has used this to develop measurement toolkits for post-traumatic stress disorder, for suicide research, and eating disorder research, and now we've embarked on doing the same for an early psychosis toolkit, both for translational research and community care. Our second initiative, which started this year, is a collaboration with the Substance Abuse and Mental Health Service Administration to evaluate the fidelity of the newly developed programs to the coordinated specialty care model and to evaluate their clinical impact. So we see that evaluation project as a logical place where we can begin to implement these standardized tools to learn how they would work in community treatment settings. And then finally, we have plans for developing a healthcare informatics platform to support the data collection, data capture, data aggregation, and big data analytics across this network. So the timeline takes us from 2016 out to 2020. And I just show you this so that you can see that actually the work is in progress. So the Common Data Elements project is wrapping up now. The expert work groups in translational research and in community-based care have finished their work. They've made their recommendations. We're in a period of public comment now, and I expect by the end of this calendar year, the final results of that process will be communicated to the field about our initial set of tools for the early psychosis toolkit. While we're finishing that up, we have started the evaluation of the coordinated specialty care programs that have been developed since 2014. We've done this in collaboration with SAMHSA and the contractor, Westat. They are currently have moved from proposing the study to now planning it. And this study becomes a perfect vehicle. There'll be somewhere between 35 and 50 clinics that will be involved in this analysis. It's the perfect opportunity for us to use these common data elements across a large number of community-based clinics and train them in the ways of integrating this standardized data capture into their routine clinical practice. The development of the informatics platform is slated to begin in mid-2017, and the idea here is to build an informatics platform that will be ready by sometime in 2019 to take the products of the evaluation study and be able to put them on this distributed network and be able to report data back to the clinics. So by the end of 2019, we expect that we'll have EPINET Alpha version, that there'll be about 30 clinics enrolled in that early phase where we'll be developing products that will help them monitor the effectiveness of their care, find areas for quality improvement, and also methods of engaging the scientific community in looking at opportunities for new research. And by mid-2020, we expect to move from the alpha phase to the beta phase, which will be the broad implementation of EPINET across the United States. So there's something to look forward to. So, you know, in this talk, I've tried to convey how NIMH approached the known problems in dissemination of research results, adoption of evidence-based treatments, and broad implementation by a new strategy of engaging stakeholders at the very beginning of the study in both defining the questions, the design, and then over the course of the study, keeping them involved about study progress so that it is constantly on their radar, refreshing their memory of this project, and preparing them to be able to accept the information that's developed by the research and use it in their policy decision process. We were very successful in engineering that kind of outcome, and we look to use that process as we go forward in the future. So I already acknowledge that this work would not have been possible without the tremendous research teams that were organized by John Kane, Nina Schooler, Delbert Robinson in the RAISE Early Treatment Program, or the program organized by Lisa Dixon and her colleagues at Columbia and Maryland Psychiatric Research Center. I've mentioned the key stakeholders involved, and here in this last slide, I just want to acknowledge my NIMH colleagues, Susan Azrin, Amy Goldstein, Joanne Severe, and Michaela Scanlon, who've worked with me from the beginning on the RAISE project, and then also Beth Bowers, Yancey Bodenstein, and Laura Seiss, who provide invaluable service in collecting and organizing the data that I presented to you today. So with that, I say thank you, and I'll see you in 2018.
Well, thank you, Bob, for that tremendous talk. I think we are all very impressed with what you have achieved during the last 8 years. I came to think of an event I was attending in Denmark. I had a dinner with an American visiting researcher, and it was just after the Virginia school shooting, and apparently this person who did the school shooting was mentally ill, and I said, oh, he could have been helped, and this could have been prevented if you have had early intervention services. It might be. And he said, oh, that will never happen in America. And I think now you have proved, Bob Heinssen, John Kane, Kim Muser, Lisa Delbert, Delbert Robertson, Lisa Dixon, and Nina Schuler, and all the SAMHSA people and all the people who have helped you, and Barack Obama, I think we should mention also. You have proven that it is possible to do such a thing in America, and also with a very short notice. So I think we are all very impressed, and I think it's really great news for the society to see that such a big change has happened. So we are impressed with the 187 teams established in 2018, and yeah, you might still lack some in order to cover everything, but I think it's great. Okay, after that I have some few housekeeping messages. One is that there's a symposium here tonight, starting at 6. And those of you who, some of you will be sure to have a box lunch or something, a box food package, but all of you are welcome. So there was something that you should click on, but you can attend the meeting anyway. And it will be very relevant to this issue about implementation, because that's a main topic on the meeting. And then tomorrow morning at 8 o'clock, there will be some very talented young musicians who will start precisely at 8. And I think this morning a lot of people missed the opera singer, and I think that's a pity. So tomorrow, please come and listen to the music. Okay, then we have a very interesting event. It's the Angelo Cocchi Award, and I will give the floor to Patrick McGorry, who will introduce the award winner.